MC. I've been working as the professor of child and adolescent psychiatry unit since 2012, and she's been invited as the speakers at various national and international forums, and she's authored 27 publications and 2 book chapters. So it's a great honor to have you here as our chairperson, ma'am. Thank you, ma'am, for joining us. We request you to invite the speaker. Ma'am, you're not audible. Ma'am?
Oh, sorry. Thank you so much, both Dr. Shanika and Dr. Raman, for the kind introduction and the honor to present as chairperson for this session. Our speaker for today is Dr. Nidhi Chauhan, who is associate professor at the Department of Psychiatry in PGI Chandigarh. And Dr. Nidhi has completed her MD Psychiatry and has specialized in child adolescent psychiatry with her DM in child and adolescent psychiatry. And her research interests lie in neurodevelopmental disorders, early intervention, childhood schizophrenia, adolescent psychiatry, trauma and abuse. And she has many research publications to her name. One of her most recent being, treatment recommendations, factors influencing treatment decisions in children with ADHD. So she also has been the recipient of many honors and awards. So the most recent being the GC Boral Award awarded by the IPS North Zone for her academic and research work, and the Michael Hong Fellowship. She's also a member of the associate fellow of the National Academy of Medical Sciences. So Dr. Nidhi will be speaking to us today on ADHD in females. And over to you, Dr. Nidhi. Looking forward to hearing from you.
Good evening, everyone. Thank you, Dr. Priya, for a very warm introduction. And thank you, IPS Tamil Nadu chapter, for giving me this opportunity. I actually feel humbled and honored to be here for speaking on a topic which is very relevant in today's world, in today's contemporary society. So thanks a lot for letting me being a part of this event. So I'm sharing my screen. Please let me know if it is visible and if I am audible.
Yes, ma'am. Visible and audible.
Okay. So the topic that we've chosen for today's webinar is Attention Deficit Hyperactivity Disorder in Females, Hidden in Plain Sight. So in this webinar, I'm not going to go into much details about the neurobiology or the numbers, etc. What I've tried is to keep it a very clinical and a practical talk. Much of the focus being in generating awareness, in recognizing as to when we should evaluate for ADHD in females and what can we do about it. So, as I said, the aim of today's presentation is to understand the atypical presentations. We know that ADHD is a very common neurodevelopmental disorder, but at the same time, we know that it is generally seen through a male hyperactive lens. It's mostly the boys and the males that come to us and who are diagnosed as ADHD. Girls, females are very less in numbers. But that the girls and females do not have ADHD is not the case. Probably it is under-recognized, and therefore it comes into picture, it comes into light when they already have some comorbidities. So to understand these atypical presentations, why the diagnosis gets missed in early childhood in females, and what can be the clinical implications of misdiagnosis of ADHD in females and various life stages a female has to go through the lifespan. These are certain issues that I'll be covering in my today's talk. So why focus on females? We know that childhood prevalence, if we talk of childhood prevalence of ADHD, overall school-going children, it's around 5 to 7%. For gender ratio, we know that boys are diagnosed more with ADHD compared to girls, especially during early childhood years and the school-going years. However, when we look into the prevalence figures during adolescence and adulthood, we usually notice that the prevalence is across the genders is almost similar. So why is it so? Why is it that during childhood and early school years, females are diagnosed less, it's more of boys, whereas in adolescence, young adulthood and adulthood, females and males have almost a similar gender ratio. So there must be something. It's not that ADHD does not occur in females. It may have to do something with the recognition system, the awareness, and the way we pick up symptoms of ADHD, especially in females. Diagnostic rates also show a marked gender gap. Females, as I said, often are diagnosed later during adolescence, adulthood, and often even during adolescence and adulthood, they are diagnosed incorrectly. And during the later part of the presentation, I'll be discussing some of the issues as to how incorrect diagnosis or misdiagnosis can happen. And females often have a comorbid axis 1 disorder diagnosis first before they are diagnosed as to be having ADHD in the background. So a brief recap about ADHD. We all know that ADHD is a neurodevelopmental disorder. When we say it's a neurodevelopmental disorder, we know that it's there in the brain when the child is born. The age at which manifestation occurs or the impairment start presenting or start impairing the socio-occupational or the socio-academic domain of an individual depends upon many factors, including intelligence, including comorbid physical disorders, including comorbid other neurodevelopmental disorders, and many other psychosocial factors. The core symptoms is the triad that we know of: inattention, hyperactivity, and impulsivity. We also know that these symptoms change across development. They are different during the childhood and the early school years, and during adolescence and adulthood, they change their shape. So we can see through this graph that how the symptoms, the triad of hyperactivity, impulsivity, and inattention change during the lifespan of an individual. During the preschool and the elementary years, the hyperactivity depicted by the smaller dotted lines and impulsivity shown by the solid dark line, they take precedence over inattentive symptoms. Inattentive symptoms shown by the broad dotted lines. So as an individual grows and comes and becomes an adolescent, what happens is this hyperactivity, this is the natural trajectory of ADHD symptoms. The hyperactivity, impulsivity tends to decrease, and inattention, as we can see, tends to increase. In adolescence, there is a slight increase in the impulsivity domain of ADHD, and more so this has to do with the adolescence phase of an individual because of the various hormonal and the physiological changes that occur about, and the cognitive and the brain development that is occurring at this stage. So there is a slight increase in the impulsivity that happens. However, after that, impulsivity, hyperactivity continues to decrease through adolescence and adulthood. However, this inattention remains at a much higher level compared to adulthood and adolescence. So as I said earlier, the prevalence in adolescence, adulthood across genders is almost similar. That means it's more of inattentive symptoms during adolescence and adulthood, and it's the inattentive symptoms primarily probably in childhood in females, which usually get missed, and therefore we are not able to diagnose girls with ADHD during childhood. Okay. So what can be the gender differences in ADHD presentation? So these are very general, majority, not exclusive to males and females. Even, for example, this hyperactivity, males usually present with external and disruptive symptoms. However, it is not necessary, it is not 100% that females do not have hyperactive symptoms or impulsive symptoms. They also do have, but majority, most of them, males do present with external disruptive symptoms. Females they have an internal restlessness. Inattentive males often present with academic underperformance. However, females are usually referred to as daydreaming, very silent, quiet girls. And so therefore, this picture, daydreaming, silent and quiet girls, often go unnoticed, and it's the academic underperformance which comes into the forelight, and therefore referral also happens. Impulsivity in case of boys, it's behavioral, whereas in case of females, it is emotional impulsivity and verbal impulsivity. Emotional impulsivity means when there is a poor control, poor regulation of one's emotions, and there is a strong expression of our raw emotions. I'll talk about it in the later slides. So it's more of behavioral in females and lesser of behavioral problems in females, and these are more of internal restlessness, of being a daydreamer, of being a silent, quiet girl, and having more of emotional issues, emotional regulation problems. Comorbidity, we often see. Comorbidity, as we often see, is mostly oppositional defiant disorder and conduct disorder in males, and it's mostly anxiety and depression in females. So this is a chart which shows the gender differences, not just in the triad of hyperactivity, impulsivity, inattention, but also in the other psychosocial, cognitive, and the psychiatric variables. So this is boys, girls, and this is men. This is adolescents, early childhood and adolescence, and this is adulthood. Hyperactivity, impulsivity throughout has been seen to be more in females more in males compared to females, whereas inattention, low self-esteem, poorer coping skills, IQ issues are seen mostly in females during childhood and lesser in males. However, it tends to be almost similar when it comes to adulthood. Inattention tends to be more in females even in adulthood. Deficits in executive functioning is the same in both males and females. There is more of anxiety and depression in females, more of ODD and CD in males. However, in adulthood, it is almost similar. For some, the scientific data that we currently have is not strong enough to conclude anything about that. So coming to the first case vignette, it's not the case vignettes that I'm presenting here are very pointed case vignettes, I would say. These are not elaborate case discussions as we have during our case rounds or case presentations. The point here is to highlight certain issues with respect to the aim of the talk today. So the good student. So Miss A is a 9-year-old girl. She is academically average to above average. She takes excessive time for homework. She is reported to be forgetful. And at home, parents report that she has emotional outbursts quite often. However, the school does not have any such complaints from this girl. So what is happening here? School, in a way, provides a structured environment. And what happens is when the school provides a structured environment, the impairments tend to manifest less. Academically, she's doing good, average, above average. It's mostly the academic difficulties, the behavioral problems the schools are more concerned with. And if a child does not have any academic issues or does not have any behavioral or disruptive problems, they usually do not come into the limelight and therefore are not asked for any referral. However, when we take the history from parents, they do report that she takes excessive time for homework. That means she has some issues with attention, with concentration, maybe distractibility. They also report that she is forgetful. She often forgets her things. She does not keep her things properly. They also report that she has emotional outbursts at home. So emotional outburst or emotional dysregulation problems often occurs in the safe spaces. So this is also another thing that has to be taken into account. And as such, no school complaints. So thereby saying that if there are no school complaints, saying that ADHD might not be there would be wrong in such a case, because there are other factors which are playing a significant role, and these are causing impairments in day-to-day life, and these, if not addressed at the correct time, are going to lead to many problems later in life. So the question, why girls like Miss A get missed? So as I've already talked, that whenever there is a low disruptive behavior, there is less overt hyperactivity. The quiet girl is not disturbing the class, is not creating any problems in the class, is doing good academically, will not come into the limelight and will not get referred for any evaluation. Also, what happens is girls are often known to be very compliant, and they often are very quiet, and therefore their problems do not come into the limelight. The inattentiveness which is there, the teachers may interpret as lack of ability rather than that it might be stemming from some of the issues that the child might be having. What happens is that many girls, they copy their peers, they rely excessively on their parents, they become over doing things. They become perfectionist over time. And this is the coping that they usually undertake to cover up many of their symptoms. So as a result, what happens is the inattentive part of ADHD in girls get missed. So what is masking and overcompensation? So these are two coping strategies which girls with neurodevelopmental disorders often are reported to utilize in very huge numbers. These are very common strategies and have been reported in literature to be mostly utilized by females. Masking, as the name suggests, is intentionally shifting your behavior to hide some of your differences. For example, and overcompensation is overdoing things. For example, waking up, working late at night to overcompensate for not staying over the deadlines to complete your work. So you're working late at night. You become a perfectionist. You know that you are making mistakes. There are certain issues that come about in your work. So what do? You tend to overcorrect. You tend to check, and become a perfectionist over time. Over preparing for things. There should not be any mistakes, fear of failure, repeated negative feedbacks that a child gets. So therefore, they over prepare themselves for this. They become overly helpful also to hide some of their deficiencies. They might avoid challenging tasks. They might not take up those tasks where they find that it will be very difficult for them to cover up those tasks or complete those tasks. They often observe their peers as to how they are behaving in particular situations, in particular activities, and they often copy or mirror their behaviors. And as a result, they are able to hide their differences, their deficiencies, but it comes at a cost of emotional exhaustion and at a very high cost of mental health, which becomes apparent later in life. So we come to the case vignette to the anxious adolescent. So she is 15 years old. She has presented with excessive thinking. She reports, and the parents also report, of having chronic anxiety. She procrastinates things. She often reports that she feels as if her mind is never at rest. She also has emotional breakdowns right before the exam. She has severe anxiety, almost amounting to panic attacks. She also reports of sleep issues, initial insomnia, because she feels that her mind is not at rest and therefore she's not able to get sleep. She has always found it difficult to focus, which has made her more anxious. And as a result, what she does is she self-harms to deal with her stress. One second. Is my screen visible or it's fine?
It's visible.
It's visible.
Okay. So there is self-harm to deal with her stress. So what is happening? What would anyone diagnose this girl as if she presents to you as in the very first go? Anyone would label her as having anxiety problems. Maybe she's having sleep problems and therefore anxiety. However, what the parents say is that even after she has been treated for anxiety that she has been reporting for quite a long time, there is partial response to anxiety treatment, and she has not done very well despite being on regular therapy. So how do we differentiate if it is a ADHD-like impairments or if the impairments or the root cause is only anxiety and depression? We always go back to the history, the childhood history. We often know that complaints of childhood will often arise during the childhood years. And as DSM-5, ICD-11, they say that the problems must be there before 12 years of age. So ADHD manifests during childhood before 12 years of age. Anxiety often has a later onset, although it cannot always be said that anxiety is often after 12 years. Even younger children do report anxiety and they can manifest with anxiety. However, the quality of anxiety symptoms and the quality of impairments because of ADHD inattention will be different. And therefore, a deeper dig into the impairments and the quality of their impairments would make a difference and would help in teasing out why the issues are there. In case of ADHD, this is 100% sure that attention difficulties would be present before the onset of anxiety. And in case of anxiety disorders, anxiety symptoms will occur first, which will then lead on to attention difficulties. So attention difficulties will be the consequence of anxiety. In ADHD, task-specific attention problems are reported. For example, we often see parents reporting to us that if the child comes and sits with the mobile or with the television, there is no problem at all, absolutely doing fine. However, when it comes to academics, when it comes to some sitting jobs or doing some desk jobs, then there is a problem. In case of anxiety, it is a pervasive phenomenon. Interest-based functioning is seen in ADHD. However, anxiety presents with global low motivation. In ADHD, distracting thoughts are random. Often, what individuals, as this girl is saying, the mind is not at rest, but what is the quality of the thoughts that are coming in the mind, whether they are positive or negative, it's just random. Anything can come into my mind. Whereas in anxiety, it's mostly negative thoughts. External distractions are not always distressing in cases of ADHD, and we often see that at times children with ADHD, in order to keep themselves focused or concentrated at a task given to them, they often engage in some kind of hand movements. Their legs are tapping just to keep them focused or at a particular task. And in cases of anxiety, external distractions are more likely to be distressing. Fidgeting helps become alert, as I just mentioned. In anxiety, fidgeting helps calm down the anxiety. Inattention is a trait in ADHD, whereas it's a state in cases of anxiety. Another thing that is mostly in adolescents, when they usually present as this girl, self-harming herself, sleep issues, emotional outbursts, and panic before exams. These are often mislabeled as attention-seeking behaviors, as borderline traits, and often misdiagnosed as having borderline personality disorders. So again, here it's important to understand the things that may be arising because of ADHD and may not necessarily be because of the borderline personality issues. So the most common thing that comes here is impulsivity, which is common to both ADHD and borderline traits. Impulsivity in cases of ADHD is linked to boredom, hyperactivity, but may also manifest in cases of relationships because impulsivity is a transdiagnostic construct, and it has impairing a role in almost every domain of life. But when we talk of borderline personality, we often see that impulsivity is mostly linked to relationship difficulties, and there is a fear of abandonment. So this fear of abandonment will not be there in cases of when there is ADHD in the background. Emotional dysregulation is linked to core ADHD symptoms. As I said, emotional impulsivity. So what the literature says is that impulsivity is not just motoric impulsivity that is often mentioned in DSM criteria and the 9 items that are there in hyperactivity, impulsivity. But the literature now also says that as a child grows into adolescence, adulthood, what happens is that this impulsivity manifests into 4 different kinds of impulsivity. For example, verbal impulsivity. The individual would keep on saying something and this would become a problem because it would be just anything at random. Then there is cognitive impulsivity, poor decision making, poor contemplation as to what would happen. So cognitive impulsivity. Then there is motivational impulsivity, wherein the individual is not able to delay rewards, and delayed gratification becomes a problem. And this usually happens. So then comes the emotional impulsivity. Emotional impulsivity is considered to be central to the ADHD symptoms, although it is not as one of the diagnostic criteria or as diagnostic symptoms in cases of ADHD. However, if we go through the previous nosological systems and we understand as to how these emotional symptoms came into picture with respect to ADHD, these were first described initially as emotional symptoms when ADHD was understood as arising out of kind of minimal brain dysfunction, the early 1950s, 60s understanding of ADHD-like symptoms. Gradually, as the nosological systems progressed and new systems came, emotional symptoms, they become associated features and eventually got lost somewhere. However, again, now this DSM-5, ICD-11, although do not have emotional impulsivity or emotional dysregulation as one of the more common symptoms. But literature now says that because of its impairing symptoms and because of its, if it being a very central feature of ADHD impairments, should be considered as one of the diagnostic criteria. So, emotional dysregulation in cases of EUPD is linked to relationship difficulties and is not central to the other symptom domains. Identity in case of ADHD is not necessarily unstable. However, borderline, we all know, often comes with identity issues. ADHD, because of the inherent hyperactive, impulsive, and other problems, negative interactions with the environment around them, do come up with social issues, but these social issues arise because of forgetfulness and impulsive communication. However, in cases of EUPD, social issues are due to feelings of insecurity, of relationship issues, and therefore these are core diagnostic differences. These are core diagnostic differences that should be looked into when an adolescent girl especially presents with self-harm attempts, self-harm or non-suicidal self-injury, chronic anxiety, and panic symptoms. So this should be looked into. So emotional dysregulation in females, as I was saying, emotional dysregulation refers to difficulty in controlling and regulating emotions. So the triggers for emotional dysregulation can be internal or external in cases of ADHD. At times, the emotions that come, they seem blown out of proportion and even take the shape of a meltdown. So it is very common. It is very impairing. However, this domain is often ignored diagnostically. How it presents is it presents with rapid mood shifts, with intense emotions, with high anxiety, severe meltdowns. The girl finds it difficult and struggles to take away focus from one's emotions. There is very low frustration tolerance. There is very high rejection sensitivity. And one finds it's very difficult to soothe and calm oneself. And all of this is associated with shame and guilt. So if we look at this picture, low frustration tolerance, rejection sensitivity, difficulty soothing, high in anxiety, intense emotions, anyone would diagnose these as borderline traits or attention seeking behavior. Now, what we do not realize here is that where are they stemming from? So the question to be asked is where, not why is why is she having, why is she so anxious, or why is she having this? The problem is where is it? What is she doing? What is she trying to manage that she is manifesting like this? So probably this becomes very important while we are evaluating young adolescent girls who present with these kind of symptoms. And we often have a tendency of labeling them as borderline traits or borderline personality disorder. And there is enough literature now which says that adolescent girls, young adult females who have been diagnosed with borderline personality disorder, and if they are evaluated retrospectively, information is gathered retrospectively, they often have ADHD in the background. So what is the impact of this emotional dysregulation? So they are multifactorial, and it is like every domain of life is affected. Workplace difficulties because of inherent ADHD symptoms and impairments, meeting deadlines will often be a problem. Because of impulsivity, because of emotional dysregulation problems, interpersonal relationship with peers and colleagues and seniors will be at stake and at risk. There will be academic struggles. These individuals find it harder to concentrate, learn, be productive, and as such is a source of intense stress for them. Relationship problems, mental health struggles, comorbid axis 1 disorders, and there is a high tendency for risky behaviors. So it becomes very important to identify impairment symptoms because of emotional dysregulation and not just the symptoms which arise because of hyperactivity, impulsivity, and inattention, because there are many other domains, many other impairments which come into picture as an individual grows. So this was one of the study wherein they studied just recently published in 2025, where they studied the emotional dysregulation in females with ADHD. What they did was they took 176 women between 20 to 30 years of age, wherein 82 had a reported diagnosis of ADHD and 94 did not report of a known diagnosis. So they assessed the ADHD symptoms and its severity, the executive function deficits, emotional dysregulation, alexithymia, positive effect and negative effect. The findings reported that emotional dysregulation was associated with ADHD symptom severity as well as with executive function deficits. And individuals and women, these young women who did report of these problems, they often used non-adaptive emotion regulation strategies leading into negative affect and alexithymia. They also reported that executive function deficits, working memory, and task shifting, it mediated the relationship between ADHD symptoms and emotional dysregulation. So, executive function deficits also lie in the background and are a central part of ADHD symptomatology and its impairment. And when we kind of evaluate individuals with ADHD, more so females females with ADHD, the impairments arising because of attention of executive function deficits often are overlooked and not paid due attention. So this is an adult female about 32 years old. I hope I have the name. Okay. So this is a 32 years old female who has presented with chronic feelings of overwhelm. She has recurrent depression. She has been diagnosed as a case of recurrent depression. She's done many jobs, however, she could not sustain any of the jobs, and there is a high job instability. And she also reports of relationship difficulties. So, if such a female comes to us, we would often, most of us would diagnose this as a case of recurrent depressive disorder with maybe some interpersonal issues. But attributing job instability, relationship difficulties, all because of depression seems a little wary as to why such kind of a thing should be happening. So what we need to understand here that ADHD symptoms, as I've already mentioned, it's a neurodevelopmental kind of a disorder, and therefore we do not call it as an illness. It's a condition which is there till the individual is there. So it remains with the individual throughout the lifespan. The form and the manifestation and the presentation keeps on changing depending upon the age and stage of the individual, and also depending upon the demands on the cognitive capacities, on the cognitive reserves, and the other societal demands that are put up for the individual as the individual grows. So when we talk of preschool and school age children, we most often we see that behavioral disturbances, academic problems, concentration problems, or any other comorbidity for that matter, physical or neurodevelopmental comorbidity are the main problems. In adolescents, academic impairment continues, poor social interaction, lower self-esteem, substance use, antisocial behavior, high-risk behaviors, they come into the forefront, along with the problems that have been continuing through childhood. In young adulthood and adulthood, academic failures, not able to cope with daily tasks, forgetfulness, disorganized, unable to plan anything, substance use, high risk behavior, relationship problems, marital discord, emotional regulation problems, mood instability, so many things come up as an individual grows. So, as the societal demands increase, the manifestations change and take different presentations, and it's very important to consider these while we are assessing. Also, if we talk of a female here while we are talking, so the female has to undergo a lot of changes when it comes to childhood through adolescence and adulthood. Many transitions that take place through her life, to being a parent, to embracing motherhood, transitions across the various phases of life, and these are very important. So in childhood, inattentiveness, emotional sensitivity, as often parents report that she was very sensitive while she was a child. She was very well behaved, but she was too lazy to complete her tasks, and she was very compliant. So these are the main complaints that we usually get for children, for girls, especially the inattentive type, because it's more common in girls, during adolescence, because of the phase of this life, because of the physiological processes that are taking place, emotional dysregulation takes the top seat. And as a result, other mental health problems, low self-esteem, anxiety, depression also creep in. Going into adulthood, burnout, chronic overwhelm, depression, anxiety, relationship issues, etc., they take a part, and they take the main seat when a female becomes an adult. Alongside this, what happens is hormonal transitions also happen in case of a female. For example, puberty comes. So as puberty comes, then there is pregnancy, then there is perimenopause and menopause. So we also now have enough literature to say that these hormonal transitions also tend to worsen symptoms of ADHD. They tend to affect symptoms of mood, of emotional regulation, and concentration, attention. As a result, these females are often misdiagnosed when they present. The most important thing that one should look here is symptom fluctuation occurs across the menstrual cycle. For example, when the menstrual cycle is about to be there might be sudden mood changes. If during pregnancy, there might be sudden mood changes. After becoming a mother, when a new motherhood is embraced, there might be some problems. During perimenopause and menopausal services, symptom fluctuation may occur, mood instability, depression, anxiety might be there. So it is said that estrogen, it modulates dopamine transmission. So it has a facilitatory or a protective or positive feedback mechanism for dopamine. So whenever these hormonal transitions phases occur in a life of a female, there are low estrogen levels. When there are low estrogen levels, the inhibitory effect is taken away. As a result, inattentiveness, concentration difficulties, mood lability, emotional problems all come up to the surface. And therefore, this also becomes a very important. So, vulnerable periods like the premenstrual phase, postpartum, perimenopause, menopause, pubertal, they become very important. As it is, girls were often missed having the diagnosis of ADHD, mostly inattentive type, during childhood. Adolescence is the period when this is often unmasked because of these hormonal transitions and the impairments coming into the fore. Okay, so having understood this, what should we do? So the one thing that is very important for us to understand is that we should look beyond hyperactivity. We know that females with ADHD may have hyperactive symptoms and impulsive symptoms, but predominantly they often present with inattentive symptoms. As it is, hyperactivity, impulsivity is going to be noticed by everyone and is going to be referred to you. However, the inattentive symptoms are hardly noticed by anyone unless there's a significant problem or there are other comorbid and neurodevelopmental issues. Only inattentive type is definitely not going to be referred to you, and referral bias also creeps in here. It is very important to take a detailed developmental history. We all know that to make a diagnosis of ADHD, there are certain diagnostic criteria that have been laid down in ICD-11 and DSM-5. The age of onset should be before 12 years of age. They have listed out certain diagnostic criteria. However, here I would like to mention that the diagnostic criteria that have been mentioned are mostly male centric. They have been normed on male samples, and the female symptomatology or presentation has not been taken into account. So that also needs to be kept in mind, and the exploration should be done according to the gender specific presentations that are there in ADHD. One should always ask beyond school performance. As I mentioned in the first case, the child was academically average, above average student. There were no school complaints, there were no behavioral issues. However, issues did manifest at home. So it is always good to ask beyond school performance. It is very important to focus on functional impairments rather than just counting the symptoms. 6 out of 9 in DSM-5, in hyperactivity, impulsivity, or inattention. It's important to focus on the functional impairments. One should actively screen for masking and overcompensation strategies in case of females, because these is a very significant proportion that forms a part of a female's life, and should be very carefully taken into account. And one should always go ahead with the gender sensitive examples. So it is very important to ask that, for example, how much effort does it take to keep yourself organized? One simple question, but how much effort does it usually take? May ask about daydreaming, about mental fatigue, about time blindness, about a feeling of chronic overwhelm, a chronic anxiety, not able to explain as to why this is there. So it becomes very important. So rather than counting just the symptoms, the criteria that are there, it's important to look into the impairments too. So as I said, taking a developmental history becomes the core when we have to diagnose ADHD. The key questions what we can ask, which are usually not given in the diagnostic criteria, is, for example, Was she forgetful or dreamy as a child? Did schoolwork take excessive time? Were there emotional meltdowns at home? And was there any pattern of underachievement that you've noticed? She was doing well during childhood years, but as adolescence and puberty hit, academic decline was noticed. She was seen to be more inattentive. She was seen to be not focusing on certain things. So, a specific questions should be asked for while evaluating a female for ADHD. The rating scales and tools are very well known and they can be used to support, but these do not replace clinical judgment. So there are various tools that can be used for example, the Connors ADHD rating scale, the Vanderbilt parent as well as teacher ADHD rating scale, the adult self-report scale. DIVA is the diagnostic interview for ADHD in adults. 2.0 version offers a 3-part history, which also encompasses evaluation of the childhood history and the impairments that may be there because of ADHD as a ADHD during childhood. So there are important tools and scales which can be used, but obviously these do not replace clinical judgment. And a clinical judgment and a detailed clinical and a developmental history always remains the cornerstone for such evaluations. We know that females may underreport inattentive symptoms, so specifically focusing and asking for inattentive symptoms becomes important. As I mentioned, impairments because of emotional dysregulation, because of attention deficits, executive dysfunction, they are often missed. So therefore, pointed questions to these things should be asked. As I've mentioned earlier, so common misdiagnosis in females is usually because they present during adolescence, young adulthood. So you often get a diagnosis of anxiety disorders, depressive disorders, personality problems, adjustment problems, and the core issue as to why this is happening is often overlooked, and the Axis 1 disorders are usually managed. But it so happens that even the almost holistic management of Axis 1 disorders do not result in a full remission or significant recovery in case ADHD is there in the background. Management in cases of ADHD, as we go in general for ADHD, is multimodal. It involves many professionals, paraprofessionals. Psychoeducation becomes a very, very important part for females who did not have the idea as to why they had so many struggles and why they had this unexplained anxiety. They find it very relieving when they get to know that these symptoms were because of ADHD, and therefore psychoeducation as to what ADHD is, what impairments it can cause beyond hyperactivity, impulsivity, and inattention often gives a sigh of relief to these individuals. As effective, we see that stimulants, non-stimulants, they are effective in males. Similarly, they are equally seen to be effective in females. The only dictum we always follow is start low, titrate carefully, because most of the literature that we have is from the Western literature. Indian population may require slightly lower doses. They may have a higher propensity for side effects. So therefore, it's always better to start low and titrate carefully. However, the medications are the same as used for males. For example, methylphenidate, atomoxetine, mostly in cases of females because they usually come with a comorbid diagnosis of anxiety disorder or depressive disorder. It's better to start atomoxetine because it handles both anxiety depressive symptoms as well as ADHD symptoms. It is very important to monitor mood symptoms and anxiety symptoms to see for any cyclical changes that may be occurring during the phase of the cycle of the menstrual cycle in cases of reproductive women, and maybe some kind of perimenopausal or menopausal worsening of symptoms, and accordingly the doses of the medications can be adjusted depending upon the symptom presentation during these phases of life and during these phases of the cycles. So adjustment of doses across the life stages if needed should be done. Psychosocial interventions remain the same as for other adults and males for ADHD. For boys as well as girls, psychoeducation becomes very important. Even in children, I would say psychoeducation, when children get to know as to why they are struggling, and they get to know at least that there is someone who's understanding their problems, it brings about a great sense of relief for them, and it also helps in building rapport with the child, which helps you in continuing with your therapy and management. So ADHD adapted CBT should always be kept into mind. For example, time management, how it should be done should always be looked into. Procrastination should be addressed, emotional dysregulation problems should be handled, executive function coaching should be done. The EF deficits, for example, working memory deficits, set shifting deficits, they are very prominent. So how can these be managed should always be discussed. Daily planners, short-term goals, they are very helpful in individuals with ADHD because long-term goals, fulfilling long-term goals, planning for long-term goals is a difficult task for them. However, given shorter tasks, simpler tasks, it becomes easier for them to follow and manage. So what is the cost of misdiagnosis? I've already mentioned the developmental impact and the lifespan impact of undiagnosed and untreated ADHD. Overall academic underachievement, chronic low self-esteem, recurrent psychiatric morbidity, burnout, and functional decline are the major things that are there. Substance use, risky behavior, incarceration, legal problems. The list is endless. So it has a huge cost if the diagnosis is missed. So what are the key clinical pitfalls? The first one, that if a child is doing good, rules out ADHD. However, we know that even children with high intelligence may have ADHD. However, what prevents the manifestation or what prevents the other people to notice the impairments, it's maybe a good external scaffold, that is parental support, good structure at home, a good structure at school. So all these prevents the manifestation of the impairments. And as these scaffolds weaken, for example, into adolescence, adulthood, when parental supports are lesser, when there are lesser structured daily routines, so these manifestations become more apparent. So assuming that good grades rules out ADHD is wrong. So even children doing very well in academics may have ADHD and they may be struggling in other areas of their life. So it's important to even to evaluate for ADHD in such individuals too. Over pathologizing emotionality, for example, emotional dysregulation. She's coming with self-harm attempt. She's coming with so much emotional problems. So might be a borderline personality trait, not understanding as to what is causing these, what is she managing that is leading to such problems. So over pathologizing things. Ignoring EF deficits is very common because these are not listed in the diagnostic criteria and we often tend to overlook these symptoms. So looking for these problems becomes very important. Treating comorbidities in isolation, anxiety, depression, only treatment of anxiety, depression, not trying to make an effort, not trying to make an attempt to understand why this came about, how the genesis of these problems came about, leads to incomplete treatment and partial remission. So take-home message from this talk could be that ADHD in females is very common. It is real. However, we know that it is under-recognized. There are many reasons for why this is under-recognized, not diagnosed in females early on in life, and even in later life, it is misdiagnosed as primary access 1 disorders, not as ADHD per se. So there are many reasons. Presentation is subtle. It is not absent. So even if there are lesser females with a diagnosis of ADHD, does not mean that females do not have ADHD. Their presentation is subtle. There are other strategies that they are utilizing as a result of which impairments become less manifest. Emotional dysregulation is central, and I've highlighted that. Developmental perspective is very, very important. Hormonal transitions through a female's life is very important to take into account. Masking and overcompensation delays the diagnosis, but it increases the mental health cost. Early recognition definitely changes trajectories, and there is no doubt about it. So she wasn't failing to cope. She was coping with an invisible disorder. And so our main aim should be to make that invisible disorder visible, and generating awareness becomes very important in such cases. So these are my references for the talk, and thank you.
Thank you so much, Dr. Nidhi. Yeah. Thank you so much, because this was a very excellent talk. Getting issues in ADHD in females, right from the symptom, manifestations, the changing symptom profile, to how it's often missed because people don't often look for it. So we'll just go to would anybody like to put in any questions in the chat box? Would anyone like to ask any specific questions?
People are still thinking what it was all
Yeah.
about.
Or you've explained it so well that they don't have any more questions to ask you. Yeah.
Can I start with?
Yes, Dr. Shanika.
Ma'am, do we have any specific psycho education modules for females specifically? Because it's always the psychoeducation modules focus more about the male presentation of ADHD. Do we have any specific modules for females per se, which will be easy to educate the parents?
Not that I am aware of, Dr. Shanika, that a female-specific ADHD psychoeducation module is there. But even like Western literature and Western guidelines, they do have some consensus statements that are there. But when we come to Indian context, we do not have any specific female, or that I am not aware of. Maybe there are, but whatever literature search I did do, I did not find any female-specific psychoeducational modules. The important point here I would mention is that even in those psychoeducational modules, a lesser impact or lesser importance is given to the symptoms that may be arising because of emotional dysregulation or because of executive function deficits. Most of the symptomatology or the explanation that is usually given in these modules is often mostly focused on the triad, the hyperactivity, impulsivity, and inattention. And if we gather more information, we know that this triad is just the tip of the iceberg. There are a lot of things beneath that, the ADHD symptoms and the impairments because of that. But maybe that's a nice question. I will look into it. And if I get one, I'll definitely share it with you.
Thank you, ma'am. Thank you. Ma'am, one more thing, a clinical challenge we always face is to, educate the family about the comorbid ADHD, because it's always the presentation is the emotional and behavioral disorders. They come with comorbid anxiety and depression. And many times parents dismiss saying that there's no hyperactivity. Why do you diagnose my adolescent with ADHD? So that's how parents ask us questions. It's sometimes, even despite the assessments we do, it's sometimes very challenging to convince the families with diagnosis of ADHD, comorbid ADHD. How do we educate when it's, because they say right away, they dismiss saying there's no hyperactivity, no hyperactivity. And how do
This
we?
is a very common clinical challenge. And just about 2 or 3 days back, when I was in my OPD, and this was a boy, not a girl, right? So I was talking to the parents. The mother was in like kind of denial. Ki nahi. So she was underreporting. I could see that she was underreporting symptoms. But what I often do is I start explaining symptoms. This might not be the presentation in your child, but these are the various symptoms or the various impairments that come about because of ADHD, because of hyperactivity, impulsivity, inattention, because of other things, emotional outburst, very sensitive, छोटी छोटी बात पे रो देता है. मतलब, I try explaining symptoms to the parents, and while I am doing those symptoms, parents come up by themselves. Yes, she or he has been doing these symptoms. Yes, she behaves like this. Yeah, I often see that when I sit with this child, he completes the work or she completes the work. But when I give a task to him or her, the task is there. So, what I often do is I explain symptoms. I do not focus at the symptoms of the child. I, in general, explain the symptoms of ADHD and the impairments that come about. Parents often, in my practice, I've noticed that the parents, they often start saying, yes, this is this, he behaves like this. I think even we need to understand that not everyone, or maybe any parent, would be very comfortable in actually admitting or acknowledging that their child has a problem. So I think it's very important for us to give them time, give them space, give them the information that is required, give them time and make them understand, and offer them that we are always there to help. If you feel, you can always come back, and we are always there to help you out with problems. This is the plan that I usually follow in my practice.
Sure, ma'am. Sure, ma'am. That is very helpful. Thank you, ma'am. Ma'am, and one more thing, the challenge we face is when these ADHD is comorbid with children with borderline intelligence, especially because those children are also labeled as slow, lazy, daydreamers. And how do we exactly tease out inattention as a part of borderline intelligence and inattention as a part of ADHD, especially for females?
Yeah, this
Quite
I
difficult.
would say that if a female, if a young girl has a comorbid disorder, be it any neurodevelopmental disorder or any other problem, they would definitely come to the forefront first compared to a female of average intelligence, because it will be overlooked. So if it comes with borderline intelligence and inattentive ADHD, it is a very difficult task to actually delineate as to why these problems are because, whether these are because of borderline functioning or because of inattention. However, what I have found useful is that whenever we go in for psychological assessments, for example, getting an IQ done on a detailed scale using MISIC, for example, right? The verbal tests and the non-verbal or the performance tests. So giving them some screeners to read or write. Attentional difficulties because of ADHD are qualitatively different from difficulties in academics or something which are arising because of low intellectual capacity. So our faculty, our psychologist colleagues are very good at pointing this out and picking these up. And they help us in a very beautiful way in teasing out that these are attentional difficulties arising out of ADHD, or these are just difficulties because of low intellectual capacities and nothing to do with the attentional problems. So detailed history-wise, it might still be difficult to tease out, but if we go for further evaluations, it might be possible to tease out these symptoms.
Sure, ma'am. Thank you very much, ma'am. Thank you for the excellent presentation, ma'am.
Shainika, we have few questions in the chat box.
Sure, sir. Sure, sir. Ma'am, shall I read out the questions for you, ma'am?
I'll take it up, Dr.
Sure,
Shankar.
ma'am. Sure, ma'am.
So, one question is that we give attention enhancement tasks for children. What are tasks that can be given to female ADHD patients to improve their attention? I think attention enhancing tasks are very well known for every age group. And depending upon the age of the individual, the tasks have to be modified. Additionally, for adult patients, what planners usually help very nicely. Daily planners. What I have found useful is that if they break up their day into smaller intervals and they define their time and a task as to what is to be done when, so they find it very easy to navigate through the day with lesser of impairments and lesser problems in functioning. So I think that should help even adults with ADHD, females with ADHD. So if an adolescent is having anxiety with newly diagnosed ADHD, should we treat anxiety first, or can we start SSRI with stimulant together? So if an adolescent is having anxiety and now is again diagnosed with ADHD, so I assume from this question is that the adolescent had been diagnosed with an anxiety disorder earlier, was being treated for that, now has been diagnosed with ADHD. So my take would be to treat ADHD, because in many cases of late that I've seen is that we even in our clinical practice, individuals who have been diagnosed with, for example, generalized anxiety disorder or depressive disorder, they do respond to some extent to these to SSRIs, but there is no complete remission. There is no recovery per se. They still find there is something lacking, and they are not fully recovered. So what I have found helpful is that, for example, switching them to atomoxetine, because amongst medications for ADHD, we know that atomoxetine works well for anxiety, depressive symptoms, and ADHD. So switching them to atomoxetine helps both the anxiety and the ADHD. So rather than giving a stimulant with SSRI, I think it would be better to give the adolescent only atomoxetine and then see for the symptoms, ADHD symptoms, how much of it is left. And if still there is some residual anxiety, and as I mentioned, the quality of the anxiety is important to be deciphered as to what is the quality of that anxiety and the thoughts that are there, which will help you determine whether it's because of ADHD struggles or it is a separate anxiety disorder. So one is, many adolescent girls come with the symptomatology explained by you and a self-diagnosis of ADHD with the self-administered scales in Google, but most of them have excess screen time from childhood as a confounding factor, confusing the picture. How to go about in such cases? So I often see making a diagnosis, many people are coming actually with a self-diagnosis of ADHD because probably they are having some difficulty or the other in their daily lives. But for us as clinicians to make a diagnosis of ADHD, it is very important that we go back to the childhood history, take a thorough developmental history, and then determine a diagnosis of ADHD before age of 12 years. So if there is a diagnosis of ADHD before the age of 12 years, yes, there might be ADHD symptoms and related impairments even at this age, and therefore it needs to be addressed. Screen time as a confounding factor is a very major problem in today's world. Very young children, we often see that excessive screen time has led to inattention and hyperactivity. Now, whether they have ADHD in the background or their vulnerability to develop ADHD is getting unmasked because of this excess screen time is a very difficult thing to tease out at this stage. I don't think we have enough literature to support any of the schools of thought at this stage, but it is definitely a very important confounding factor. The important thing here is limit screen time. It is very important to limit the screen time, assess for ADHD symptoms, even if an adolescent comes with a self-diagnosis of ADHD, determine, collect collateral information, gather information from the schools, from parents, from peers, from partners, from wherever sources you can, then determine the history of ADHD. If it is there, and treat ADHD accordingly. Also, when there is emotional dysregulation and mood swings in ADHD, can we continue stimulants? Stimulants are not contraindicated in cases of mood swings and mood dysregulations. There are ample studies to say that even in cases of severe mood symptoms, stimulants do provide a protective benefit. There are studies to say that if ADHD and even bipolar disorder for that matter are comorbid and stimulants are given, it usually gives a protective effect. Stimulants provide a protective. The contraindication per se for stimulants is maybe psychosis. Absolute contraindication for use of stimulants is cardiac problems, structural cardiac defects. Apart from that, relative contraindications are definitely there. Not even, for example, epilepsy or seizures is a relative contraindication, not an absolute contraindication. So we often say that if there are good control of seizures is there, stimulants can still be given. Monitor epilepsy, monitor control. So stimulants can be given, and emotional dysregulation, mood swings are usually helped if there is no other contraindication to use of stimulants. Any problems with fertility and conception in females with ADHD? Well, I don't think there are any problem. To be honest, I haven't looked into the core literature about fertility and conception in females with ADHD. But what I can think of is that there shouldn't be any problems with fertility and conception per se. But as we know that because of ADHD symptomatology and the impulsivity that is inherent in such things, high-risk behaviors, teenage pregnancies, exposure to sexually transmitted diseases, high-risk behavior, substance use, all these become very common. So that is one area of concern or one issue that we should look into. Apart from that, I don't think fertility and conception per se, or for that matter, these medications, atomoxetine or methylphenidate per se, have any effect on the fertility and conception of females with ADHD. Is female adult ADHD due to developmental trauma? So adult onset ADHD is still a very dubious concept. We still do not diagnose a new onset ADHD in adults. Whatever case reports are there, they have their own methodological issues, and mostly in those cases also it is seen that usually these individuals had a childhood history of ADHD and which has unmasked itself during adulthood. And as I said, the external scaffolds, the other higher intelligence, good parental support, good external structures, good daily routine, parents overcompensating for the deficits in children, children themselves compensating for their deficits, all these lead to delayed diagnosis. So developmental trauma in a sense per se is a major contributing factor, but ADHD arising only out of developmental trauma is not seen or said or given in literature. However, it's a very, very important contributing factor. And if it is there, it needs to be addressed in its own right. How do you convince the caretakers that this illness is not curable? The caretakers are not accepting the fact that it is not curable. Well, I usually take the example that, for example, if you have blood pressure or sugar, it is the blood pressure levels and the sugar levels will be under control till the time you take antihypertensives and hypoglycemic agents. Similarly, ADHD is one neurodevelopmental condition. So I take this dictum also, neurodevelopmental मतलब कि दिमाग में है जब से बच्चा पैदा हुआ है तो हम इसको वहां से नहीं निकाल सकते हैं. We cannot root it out and throw it away. It will be there, but with medications, with non-pharmacological interventions, the impairments that are arising out of those problems can be subdued, can be minimized, and the individual can live their life to their maximum capacity. So you have to hammer this again and again, again and again. And as I said, explain the entire symptomatology, extend the entire list of symptomatology presentation that an individual can have. Somewhere or other, they will click, yes, this is like my patient, like my family member or my relative. So that may help. That is the only thing that you can do. You can just tell them time and again, till they accept this.
Um,
Yeah.
may I ask? This is Dr. Raman.
Yes,
Dr. Raman.
Yeah, sure. So I just wanted to know, since you just mentioned that the criteria is all just like centric. So is there any gender sensitive actually criteria consensus that is being worked up for ADHD?
Not to my knowledge, sir. Not yet.
Yeah.
Okay. Is there any, are we just like off late, like we are just looking at like early, like evolving personality, EUPD. We are just over diagnosing. I'm just based on the clinical population that we are actually seeing. I'm just hearing from my colleagues also that like in adolescence, like we are actually just over diagnosing EUPD now. So like, are these group like that has to be actually looked at specifically to just find out the hidden ADHD component? Is just one question I just have, because like off late we just see that like there are a lot of emotional dysregulation in early adolescence that is coming up, particularly in females with a deliberate self-harm associated. So when there is a deliberate self-harm associated and relationship difficulty, we tend to make EUPD and it's evolving. So previously we used to have like very rare cases of evolving EUPD, but now like we just tend to see over-diagnosing. So are these uh, adolescent population, are they also likely to have a hidden ADHD component? Is one thing that just I wanted to ask.
Thank you, sir. This is my observation also that a lot of, as I said, that young adolescents coming to us with self-harm attempts, emotional regulation difficulties, we often tend to diagnose them as having borderline traits or borderline evolving borderline personality. But having gone through the literature that is available, it is said that impulsivity is a very important phenomenon in cases of such individuals, such girls who are presenting to us. And because emotional regulation difficulties and impulsivities combine in adolescence because of the developmental stage also, the literature so far recommends that any girl, young adolescent girl who comes with such complaint should always be assessed for ADHD in the background. So it's absolutely no harm in actually evaluating for ADHD in such girls. And we might actually find ADHD in the background upon which emotional regulation difficulties and self-harm issues, these are all cropping up because there are certain issues that the adolescent girl is trying to manage. So the literature says so, for sure.
Priya ma'am, like your input on this topic will be actually, and we have one last question. With that, we will just wind up now.
Yeah, I was just saying thank you so much, Dr. Nidhi. I think it was very well presented, and you've answered the question so nicely also. I just wanted to highlight to the group that the question Dr. Raman asked, like, has the criteria been modified? I mean, do we have criteria modified for women? Right now, at present, looking at the DSM-5, we can answer no. Like, we know that the DSM-5 has reduced a little bit of the criteria for adult ADHD. Like, but for females, it's not like specifying gender-specific criteria. So that's something we need to be aware of, that we still need to use the diagnostic criteria to diagnose ADHD. even in women. But as Dr. Nidhi has highlighted, the presentations can vary because very often it gets missed because people are more aware of boys being disruptive. So even in a classroom, teachers are more aware of a disruptive boy than a girl who would be probably more inattentive. So looking at the symptom profile, we can say that they are often missed, and very often they can present with the comorbidities rather than the actual ADHD, can often get masked. So we need to be aware of this and probably look for underlying neurodevelopmental issues when we do see any particular disorder that a girl presents with. So very often we do say that in child psychiatry, comorbidity is often the norm. So I think in females, the presentation, we need to look whether there's underlying comorbid neurodevelopmental concerns when they present with a particular problem. But most guidelines which recommend treating comorbidities always do, like there are a couple of guidelines which looks at treating comorbidity in ADHD. So sometimes, like I've looked at the questions where people have said, do we treat this illness or this? It's often like what is presenting as more severe, treat that first, and then see whether the underlying problem is sorted out, or use a medication, as Dr. Nidhi said, which can address both disorders simultaneously rather than treating them with polypharmacy. So often, when there are conditions where there's comorbidity, we see prescriptions with multiple medications. So you'll have an antipsychotic, an antidepressant, ADHD medication. So that is best avoided because polypharmacy in children, is definitely not a dictum. So we should be very sure that, we're treating the condition, looking at it from what is the primary problem, and if there's an underlying issue, see whether the primary problem, once it's addressed, the underlying issue can then be treated. So avoid polypharmacy at all costs, treat the primary disorder which is presenting probably more severe, and then probably see whether the underlying condition needs to be treated subsequently. And try to see whether you can treat both conditions with a similar medication. So there are a few studies in ADHD. I think a recent study which looked at do treatment responses change in ADHD according to genders. And there is some indication that maybe they respond better to non-stimulants than stimulants, looking at the RCTs that have overall been looked at. But of course, the RCTs also have a higher male preponderance in the population, in the sample that is studied. So these are probably questions that will arise. But as Dr. Nidhi said, very often the comorbidities are like anxiety and depression, which then in situations like that, you may address it with an SNRI, which will probably address both components of disorders. So that may be a safer option than treating a child with multiple medications at the same time. So yes, so these are some of the take-home points I was seeing, but definitely there will be a lot more research. Every area obviously has its controversy. So when you change criteria for saying that you're going to have a different criteria for females, you can imagine the controversy that will erupt. It will be similar to what Dr. Nidhi said is for adult ADHD. And you're going to land up in a situation like that. So yeah, so at present, the criteria is probably going to be the same. The symptom profile probably is a little different. The comorbidities in females and males and the trajectory of response, probably there are variations we can see. But by and large, the treatment modalities at present are very similar. And when in doubt, probably observe the child over a longer period of time. And as Dr. Nidhi said, get assessments to add on to your, diagnostic like stability, just to see whether the diagnosis is actually clear. So when in doubt, obviously, don't immediately, treat the child with a medication. You can have psychological assessments, observation in structured settings before you make a plan to treat a particular child who has a condition like this. But yeah, so those were some of the points that I was thinking of. As I said, Dr. Nidhi has covered most of it so well. So thank you so much.
Thank you so much, ma'am, actually, for that comprehensive summary of today's topic. One last question is there in the chat box, ma'am, and with that, we will wind up. In ADHD with comorbid bipolar, can stimulants still be used after the mood episode remission?
Yes, stimulants are considered to be safe after remission of mood episode. However, the only thing that we often say is that stimulants may give rise to some kind of mood symptoms or psychotic symptoms when started, so monitor for that. But otherwise, stimulants are considered to be safe even in bipolar disorder and can be given with regular monitoring.
Thank you so much. Actually, the criteria thing that that was actually popping up in my mind was also the impairment in two settings. The school or usually the criteria says two settings. So, like if at all it is going to be not much complaints at school, then it's all the more going to be very difficult to diagnose this population based on that criteria alone. So that's the standard teaching that we actually do for postgraduates also. So if they say like there is one setting at home alone, then there is a different approach, and ADHD itself is like completely just not considered. So I think as you have already highlighted, the presentation has to be actually looked into across the lifespan. I sincerely thank the speaker for that lucid presentation, making this topic like open for actually many people. There are a lot of people who have just commented that like I think it's an eye opener for them to actually look at this particular presentation. So I sincerely thank the speaker for taking out your time for this. And I sincerely thank Priya ma'am for her time and the contribution to the topic. And Dr. Shainika for actually bringing both of you to this forum, and the Tamil Nadu chapter IPS for this opportunity. And thank you so much, and wishing you all a very happy Christmas and New Year ahead.
Thank you. Same to you.
Thank you.
Thank you so much.
Thank you. Thank you.
Thank you
ma'am.
again, Dr.
Thank you.
Nidhi.
Thank you.